morning, everybody. Hope everyone's been having a good week so far. We're going to start off our morning with an amazing guest lecturer. I'll give the honors to Dr. V to kind of present and introduce our guest lecturer and get started with our first.
Okay, so I'm honored actually, and I insisted. Me and Dr. Shafali had a wrestling match over who was going to, introduce Dr. Fein. This is Oliver Fein. He's the, I'm going to call him Dean, not Associate Dean. He's the Dean of Affiliations for Cornell. He's also Professor of Clinical Medicine. And more important than that, he's my primary care physician. When I came back from the Philippines with bone pain, probably I had dengue. He's the one that I went to, and he took care of me. And he always takes care of me through many trials and tribulations. I've known Ali for 47 years. He was my senior resident, my chief resident. And when he was my chief resident, he was so good that I remembered something at the time that Isaac Newton had said. And Sir Isaac Newton said, when they praised him for how good he was in his position, he said, well, I stand on the shoulders of giants. So when I became chief resident, I stood on his shoulders. He was my role model. Best resident I've ever seen, to be honest. Better than I ever was, better than anyone I've ever worked with. And then, and this is something that I'll never forget, but I was going to come back to Brooklyn to get a job either in Coney Island Hospital or Kings County. And Ali approached me and said, will you come and stay with me in Lincoln? Because I've taken the job as the head of the emergency department at Lincoln. And the only time he ever invited me to his house and stuffed me full of food and wine and got me to come back to Lincoln. Right? And since then, he's done many, many great things. He set up at Columbia, which always was kind of a bastion of the society, but not the society Ali wanted to take care of. And he went there and set up a general medicine clinic for the community, for the immigrant community, many there. And then he went to Cornell to be the dean for the associate dean for affiliation. And he did that because he wanted to get them more diverse, and he pushed to get more diversity in their student body. And he did that so they'd have affiliations with Lincoln. And when we got to play together at Lincoln one more time while I was still there, and he got them to have affiliates in Brooklyn and in Queens and all over the world. And in fact, one of the times I worked in the Philippines, I gave an ACLS course in one of the hospitals that Ali had arranged to be an affiliate for Cornell in a very poor area of Quezon City. So he's done some other great things, and he's been the chairman of the Physicians for a National Health Plan, the national chairman, the big MACA, and he's the chairman of the Metropolitan in New York City Physicians for a National Health Plan. And he's done a lot of great stuff, including giving his input to Washington, D.C. So he's going to talk about all the different health plans and how they differ, right? Trump versus Obama versus Biden versus Physicians for a National Health Plan, which he has helped forge.
Thank you, Joe, and so much like the picture. But very nice to be with you this morning, and I appreciate you all here. And we're going to talk about healthcare reform. And I just wanted to say I have no disclosures with relevant financial relationships, but as you have heard from Joel, I am the chair of the New York Metro chapter of Physicians for a National Health Program, but I have received absolutely no compensation from that organization. If anything, I have donated. So what are we going to do this morning? Talk about U.S. healthcare vulnerabilities in the pre-COVID period. Briefly, just mention the impact of COVID on the U.S. healthcare system, and then talk about a range of policy options from the ACA to the ACA, you'll get the description of what those are. Talk about Medicare for all and potentially single payer. So, in terms of, the vulnerabilities and problems that we have, uninsurance and structural racism seem to me to be very crucial and a problem in the U.S. And you as emergency physicians probably see this more frequently than many others. Here what you see is the level of uninsured in the United States going back to 1940, when you can see that close to nobody had health insurance in the United States. It wasn't something that people had. Toward the end of the 1930s, Blue Cross was formed, hospital-based insurance, and unions began to bargain for that. And we began to see some increased people with insurance. In the early 1940s, during World War II, what happened is the unions were not allowed to, in fact, bargain for wages, but they were allowed to bargain for fringe benefits. And health insurance was one of those things, and I believe that's the accident of history in which health insurance in the United States gets linked to employment. And what you see here is the insurance, uninsured rate goes down, and then there's this precipitous jump in 1965, 66, and that's because Medicare and Medicaid were passed. And then in the 70s, we begin to see 1 million more uninsured up until 2010 with the passage of the ACA, and that was not implemented right away because it got to the Supreme Court, as you all remember. But one of the provisions that children could keep on their parents' policy, adolescents, until age 26, began to drop the number of uninsured. And then when the ACA finally was judged to be constitutional, we get this drop. But as you can see, there's still a large number of uninsured. And yes, the percent of uninsured by race and ethnicity is a real problem, so that you can see here compared to whites, blacks, Hispanics, Native Americans, almost here what you see is 20% of them do not have health insurance. And the other issue of structural racism, is something that we live with. We see here in terms of hospitals that serve Black and Latinx communities are ones that have much less, resources in terms of total assets and in terms of new purchases are really discriminated against. This is structural racism. But I think equally important is the fact that we have an epidemic of underinsurance. And when you look here at the family premiums for people in the United States, and this is on average with employment-based health insurance, we are now with premiums that are over $20,000. Isn't that amazing? And that's family premiums. And if you're an individual, your premium is going to be somewhere around $7,500. But it's not just the size of these premiums that are really going, off the wall. But it's also the way in which these things are paid for. And what you can see here is that since 1999, up until the data that I have is 2017, premiums had gone up 224%. But the amount that you as an employee had to contribute to those premiums had gone up 270%. When your salary probably only went up, in fact, 64%, and inflation went up 47%, eating away at that salary increase. And then if you look at deductibles, what you find is that, the average deductible in 2017 was about $1,500. But if you worked for a small company, it was over $2,000. And yes, if you worked for a large corporation, you might get down to $1,200. And you all know what a deductible it is. It's the amount of money you have to put out of pocket before your health insurance kicks in. And when you look, many families just can't afford that amount of out-of-pocket cost. So you can see here 49% of not just poor families, but all families in the United States would have trouble putting out about $5,000 for a deductible and an insurance policy. So we have a real problem with underinsurance in this country, and little wonder that 2/3 of bankruptcies, personal bankruptcies in the United States, actually are due to medical bills and to bills secondary to work loss. So these are real problems for people in this country. And they result fundamentally in really very poor outcomes in terms of healthcare. It is estimated in 2019 that 38,000 deaths were due to the lack of insurance. And in Texas, which had the highest percent of uninsured in the United States, 18%, what you find the largest number of deaths, 6,000. So then look at the outcomes in terms of life expectancy and compare us to the rest of the industrialized world. We have the lowest life expectancy and yes, the highest infant mortality here, almost twice what it is in a country like Italy and Sweden. And I think even more embarrassing, our maternal mortality rate is 26 deaths per 100,000 live births, right? And that is roughly what? Almost 10 times what it is in Australia. And this is something that is not going down. The amazing thing is that it is going up. So here you see comparisons with the maternal mortality rate back in 2000 to 2014. And we excluded Texas here so that it wouldn't look like it was totally being driven by Texas. But what you see here is in Texas, maternal mortality rate has doubled in the last 14 years. And finally, there is the high cost of U.S. healthcare. And when you look at that, you go back here to the period of 1980. And what you see is we were part of the pack back then. But what has happened since then is that we have really become almost twice as expensive as most other industrialized nations. And what is this due to? Well, is it because our patients stay in the hospital for longer periods of time? But no, what you see here is that in fact, in the US, the number of days per person per year in hospitals is among the lowest in the industrialized world. Well, maybe that's because in fact, we're taking care of our patients well on the outpatient side, and they have more visits to the doctor in the outpatient side. But no, here we are, one of the lowest number of visits per capita to physicians in the industrialized world. Well, maybe it's that we've got too many old people, right? They cost more. But no, here we are with the lowest percent of population, over 65, compared to these industrialized nations where they're looking at, with roughly 48% of their population over 65. Maybe it's that Americans smoke too much, and that makes them sicker and costs the system more. But what you see here is that we've done pretty well in terms of the percent of population over age 15 who smoke daily. Look at this compared to, France, which is twice the number of people in the United States. Maybe it's because we pay our doctors too much. And what you see here is a comparison, particularly among specialists. And in Australia and the Netherlands, actually specialists are paid more on average than in the United States. The situation is not quite the same for local practice. Well, I think this chart begins to get more at the reasons that our system is so much more expensive than the other industrialized nations. What you see here is the number of physicians, right? And how it's grown since 1970 through 2019. But look at what's happened to the number of administrators or managers. They have really increased. And if you look at that in terms of insurance companies and the management of insurance, we're spending per capita so much more than the other industrialized nations that have universal coverage, but we here, have insurance, multiple for-profit insurance companies, and therefore have very high administrative costs. And that is also true for the providers, for the doctors in hospitals. So here what you see is that roughly 25% of U.S. hospital spending consists of administrative costs, including the salaries for staff who handle coding and billing. You probably know about this. Compared to single-payer Canada, which is 1/2 in terms of their hospital expenditure for administrative costs, 12%. And then you see this data, and it just really drives you crazy. Mark Bertolini, president of CEO of Aetna, he is getting $157,000 per day, every day, running an insurance company for Aetna. He doesn't do that anymore today, it turns out, because Aetna has been purchased by CPS. That's a whole question. So, just that you have a sense, these are the problems that any healthcare reform has to address. right? And they have been made worse by COVID-19, right? Uninsurance has gone up, right? 35 million people have become unemployed. Many of those have lost their health insurance because of this link to employment. Underinsurance is going up, as I described to you, and there is the real genuine question, who's going to pay for vaccination, actually, when the pharmaceutical industry, wants to, frankly, make a profit in that process. Poor outcomes, yes, because we have a situation of supply chain financing. You don't build up things in reserve like ventilators or PPE, things of that sort, in a system that has that kind of finance. And the consequence is pandemic occurs, and indeed you have shortages of those territories. And then there's the structural racism that we described, which has been clearly manifest in the high rate of both the incidence of COVID in minority populations and, in terms of death. So what are the policy options to deal with these problems? Yes, one could eliminate the ACA, repeal it or declare it to be unconstitutional. That's what we see right now on foot. Or we could continue the ACA and create a public option. Clearly what has been talked about by Biden. Or we could really entertain developing an improved Medicare for all or single payer system. And if you judge that that wasn't possible, either because of Trump or, for that matter, Biden, maybe we should consider a state-based single payer program. And let's consider now each of these possible options. So when the Republicans and Trump were elected in 2016, there was a genuine attempt by the Republicans to, in fact, get rid of the ACA. And their first attempt in 2017 in the House was called the American Health Care Act, or the AHCA, or in the Senate, what was called the Better Care Reconciliation Act, the BCRA. And these two policies, or two bills, had this fundamental structure. There was a desire on the part of the Republicans and Trump to shift healthcare decisions to the states, to allow states to define the essential health benefits, which is what the ACA did, and particularly to make sure that women's health was in there so that states could decide not to cover abortion. Allow states to exclude coverage for pre-existing conditions. That's one of the things that private health insurance entities really sometimes like to have. That way they can exclude expensive patients. Allow states to determine the size of the co-payments and the deductibles, and allow states to create high-risk pools, for patients with cancer or patients with, needing a kidney transplant, things of that sort. And the second thing that they were really trying to do is to cut federal funding for health care. And one of the proposals that was looked at was, Medicaid block grants. In other words, give a fixed amount of money for Medicaid to each state and then increase it each year by 1%, but not by the number of people who were eligible for that state. And clearly, that would have been a real problem with COVID And then finally, something that you don't hear about that often was the idea, let's take the Medicare program, which gives you a guaranteed set of benefits, and usually a fixed premium amount, and convert that into a program in which we would give every elderly person, $4,000, $5,000, $6,000 to go out and buy a health insurance policy that fits their needs. This is what's called premium support, and it would totally undermine the Medicare program. And what was the estimated impact of these changes? 14 million people would have become uninsured in 2018. It is estimated that by 2026, we will be back with the number of uninsured that we had at the time of the ACA being passed. There would be 14,000 additional deaths in 2018 due to lack of health insurance. And yes, a total destruction of Medicaid if in fact we ended up block grant. Little wonder that although it was very close in the Senate, they lacked one or two votes there, they didn't get these bills passed. They failed to repeal the ACA, and they failed to replace it with a Republican plan. So Trump reverted to using executive orders to undermine many of the ACA reforms. And one of the basic things that he did was include in the tax cut for the wealthy, that from 35% down to 21%. They tucked into that bill the elimination of the individual mandate in the ACA. We'll talk about that a little bit more shortly. So Trump's goals were essentially to decrease the size of the federal budget overall, cut back on federal health care expenditures, shift health care expenditures from government to the states and to people, and cut federal government employment by reducing regulations such as the FDA and the Environmental Protection Agency. And yet, one of the things that he did succeed in is increasing taxes on wealth from 35% down to 21%. And he pursued these things largely through executive orders, slashed funding for advertisements and navigators to help people buy insurance on exchanges that the ACA had set up. Talk about those in a moment. Removed ACA coverage standards for health insurance by a specific Section 1332 waivers, which allowed states to offer associated health plans and short-term limited duration insurance, which again would be much lower than eliminate cost-sharing reductions for poor people. In this state, we had a program where if your income was between 138% of poverty and 200, the entire premium for your health insurance would be paid by government. Commit work requirements for Medicaid. You've heard about that. And finally, all of these Trump approaches were an attempt to undermine the ACA without actually replacing it. So what was this thing called the ACA? The Affordable Care Act, well, notice I do not like to refer to it as Obamacare because that's a racist attempt to brand this reform. The Affordable Care Act was really a mandate model everyone in the country was required to prove they had health insurance and a market model. So what you see here is that the way in which the requirement was going to be incentivized is that if you couldn't prove on your W-2 that you had health insurance when you filed your taxes, you would be charged. And if you were just an individual, you would be charged $969 per year. Families without health insurance would be charged $2,085 per year. And if you were an employer and you had more than 50 employees, you would be charged $2,000 per employee if you did not have health insurance. So that is one of the major principles that was in, the Affordable Care Act, that mandate. But it was also very much a market model. Here, what you saw is that states were encouraged to establish insurance exchanges. That is a place where people could purchase private insurance. And if you couldn't get it on the state level, the feds had one too. And their premiums would be subsidized if your income was above 138%, which is the level at which Medicaid was boosted up to, and if between 138 and 400% of poverty level, you could get federal subsidies to purchase private health insurance. And Medicaid was expanded up to 138% of the federal poverty level. That meant $16,000 for an individual and $27,000 for a family of three. Interestingly, in this state, before the ACA, we did not, in fact, let people get Medicaid, only if their incomes were below about 89%, 90% of the federal poverty level. So 138% really meant that we expanded roughly 2 million people in the state got Medicaid through this expansion of the ACA's Medicaid eligibility. But 32 states, just decided they would not expand. And finally, the ACA improved private insurance through market reforms, coverage up to age 26 on parent policy, no pre-existing condition exclusions, and all private health insurance must cover 10 essential benefits. Here's a diagram of what was in the ACA. As you'll see, it's much more complicated than what I just described to you. The insurance reforms, yes, Medicaid expansion, creation of exchanges, guarantee issues, kids up to age 26, better coverage, preventive benefits, better coverage of prescription drugs. But there was also quite a bit of delivery system reform. That would take a whole different discussion. But if they had repealed the ACA, all of these things would have gone as well. Things like, bundling payments, accountable care organization, dual eligible, going all the way down to federally qualified folks. Little wonder that in 2016, when a new president was elected, who said, I didn't realize how complicated the ACA actually is. So there were some major accomplishments that the ACA made. About 20 million people gained health insurance through the ACA, 12 million of them through the Medicaid expansion, 8 million through subsidized private health insurance on the exchange. the pre-existing condition exclusions being applied to private health insurance was really very important. Private insurers were not allowed to drop patients who had Medicare, who had cancer or other severe conditions. Preventive care and contraception were covered, coverage up to age 26, and subsidized coverage for low-wage workers. But the ACA had some real shortcomings. It did not guarantee universal coverage. There were still 28 million uninsured in 2019. It is a market model, controlling increased demand, which is what was worried, give people insurance, care, focusing on high deductibles and co-payments as a way to retard access to care. The ACA claims to improve quality and outcomes by focusing on cutting overdue, again, a market method, reducing 30-day readmission, value-based payment, accountable care organization. And finally, the ACA transferred taxpayer money to private for-profit health insurance companies by subsidizing premiums. In fact, the interesting thing you learn when you look at this more carefully, it's the private health insurance industry wanted to absolutely. So what we're going into now, is a Biden administration that has said they're not going to consider a single payer option like Medicare for all, which we're going to talk about in a moment, but they would like, in fact, to continue the ACA and perhaps institute a public option. What I fear is that these will be pursued as the idea of making Medicare available to everybody, essentially, what I would call a Medicare look-alike, but not truly universal Medicare for all. And I think Biden will have two major alternatives, and look at these so they can hear more, think about them. The first alternative would be allowing people to buy into a Medicare Advantage program. And you all know what Medicare Advantage is. It's essentially a situation in which the private insurance company determines some of the essential features of the Medicare program. The Part A and Part B premium, the deductible, the copay, and what benefits are covered, like dentistry, ophthalmology, hearing aids, long-term care, things that, unfortunately, the traditional or original Medicare program doesn't cover. Well, the other option that he has, so that would be a kind of option to, again, expand private health insurance using a public option. The other would be a buy-in to the original Medicare program. Try to address some of the imperfections of that program in terms of Part A and Part B, deductibles, copays, and benefit limits. But the real risk of all of these public option proposals is that they leave the for-profit private health insurance industry intact, and that industry can, in fact, go ahead and compete, essentially, with the Medicare program. So why I think the public options are likely to fail is, number one, you're not going to get any savings on insurance overhead because you'll have multiple private insurers. Coding and billing will become, again, major thing that they want to control. They need to, in fact, have more administrators to do that. There would be no savings on doctor or hospital administration. Medicare costs will rise because private insurers know how to recruit well. I don't know how many of you know about the Silver Sneakers program? Well, there are some private insurers now that offer this program to Medicare beneficiaries who want to designate them under Medicare Advantage program. But what is the Silver Sneakers program? Well, it's essentially a free health club membership. And I thought about this and I said, my gosh, that's what my patients should have. That's bad. But which patients are attracted to them? You know, patients with terminal cancer, oh, they're probably anxious about it more. Patients with severe congestive heart failure, oh, you know, patients with many joint problems and so forth. Well, you know, this is a direct attempt to recruit the healthy and leave the really sick on the traditional Medicare program. So it's a kind of, you know, cherry picking and lemon dropping, such as you have in the Medicare Advantage program. And this fails to eliminate, frankly, the ACA does, any component of structural racism due to unequal financial access. So, I think we should begin to consider, and I think more and more Americans believe this to be true. In fact, in that Fox News tally, 72% of them actually said that they were interested potentially in a Medicare for All program. What is this? Okay, here's the physician's proposal from Physicians for a National Health Program. First, universal coverage with automatic enrollment. A patient presents to you in the emergency room. The wallet biopsy is done and they don't have any health insurance. Wow, what an opportunity. We'll just sign you up right here for the National Health Insurance Program. Is there any private health insurance company that would sign you up in the emergency room of the hospital? That's what's different here. They would have low administrative costs because they are a single payer, and we'll describe that in a moment. Comprehensive coverage without co-pays and deductions. No financial barriers to health. Maximum choice of doctor, nurse practitioner, or hospital. Improved quality through having nationwide health information technology. One of the fascinating problems today is that because you have multiple private insurers, they carefully guard their utilization information. Don't share it so that we don't know frequently many problems that could be addressed if we could target them for a particular population. We don't have a nationwide HIV. Expand primary care and public health. Get lower drug prices. What entity in this country gets the lowest price on drugs? Does anyone know? Pardon?
Yeah.
The VA. Absolutely correct. Why? Because the VA can negotiate for price of drugs. Medicare, by law, is prohibited from negotiating for price. What a single payer would allow us to do, it seems to me, is get to a situation where that program could, in fact, negotiate for price. And finally, this would be a publicly funded but privately delivered approach. It's what the Medicare program does. Cornell medical students tell me I should call this Medicare 2.0. And we always talk about this being an improved Medicare for all. with fair public funding. You would create a healthcare trust fund on the federal level, transfer what the employer is presently contributing to the purchase of private health insurance premium into the public trust fund, and you would probably, because the overall administrative cost is less, be able to make that a smaller contribution. Develop a graduated employee contribution based on income, not a flat premium, essentially, that everybody has to pay irrespective of their. And you probably should develop a tax on unearned income, such as stocks and bonds. But no private health insurance premium. Why? Because they are frankly regressive. The president of the company pays the same health insurance premium as his or her secretary, yet their incomes are so wildly different. And there would be no increase, frankly, in overall healthcare spending because of the administrative. So where do those administrative savings come from? Because in fact, as a single payer, you don't have to have this elaborate structure that is inherent with multiple private insurers. And that's been demonstrated. The Medicare program now has a 2 to 3% overhead in terms of administration, whereas private insurance is anywhere from 16 to 30%. In this article, actually in the Annals of Internal Medicine, right? So it's peer-reviewed on. It is estimated that $500 billion could be saved if we went from our for-profit private health insurance dominated market to Medicare for all. That's where a lot of savings could come from. And, this would be a nonprofit private delivery system under local control. Frankly, this is not socialized medicine. This is not a situation in which doctors are salaried by government, and hospitals are owned by government. That's what you have, in the UK with their National Health Service. The doctors are employed by government and hospitals owned by. No, we're not talking about that. That's what we have today, essentially, in the Medicare program, a publicly funded but private delivery partnership. And we have bills in Congress that describe this. Camilla Jayapal is the head of the Medicare for All caucus in the House of Representatives that now has 112 representatives supporting it. And it has all the principles that we just talked about. Universal, comprehensive, choice of doctor and hospital, no co-pays, deductibles, funded through progressive tax. And of course, in the Senate, Bernie Sanders has his act, very similar to the Dark-Paul bill, and it's really something that could be worked on, and developed, it seems to me. And when you ask people here, Kaiser did this. Do you favor expanded universal Medicare for all? And you see here that the majority of people say they do, 58%. But if they declare themselves as Democrats in this questionnaire, it's 81%. Independent, 60%, but even 30%. Republican. So I think this is a real option that needs to be advocated for. But, under Trump, that was just not at all a possibility. Under Biden, it looks like it may not be very much what he wants as well. So maybe we should go the direction of a state-based single payer first. That's what they did in Canada and Saskatchewan. That province adopted a single payer first. When other provinces saw what it did, they decided to go ahead and create a national program. So we do have in this state the New York Health Act. It's something that was really promoted by Richard Godfrey, the Health Committee Chair in our Assembly. It actually passed in 2015, 16, and 17. And one of our big problems was at those days that we did have a Republican Senate in the state of New York. But now, in fact, it looks like we might have, a Democratic controlled Senate. The votes aren't all in. We think there may be, 39 Democrats. Last year we had 31 that got onto this, and Gustavo Rivera, the chair of the Health Committee in the Senate. The principles, again, exactly what we just enumerated for the Medicare for All approach. And, just to go over those things quickly, essentially comprehensive benefits, primary preventive mental health, youth, inpatient, hospital, explicit mention of dental and vision and hearing because they're not covered by care. Long-term care, again, not covered well by Medicare. Free choice of doctor and hospital care coordinator, idea that Godfrey had to assist in navigating the complexities of the healthcare system. But this would be a care finder, not gatekeeper, as many HMOs have. Progressive financing, taking the federal Medicare, Medicaid, CHIP, ACA fund, putting them in a single fund. Progressive graduated payroll tax, 80% from the employer, 20% employee. Ungraduated tax on non-payroll and investment income. And New York Health would explicitly pay for the Part B and Part D premiums that are part of the Medicare program. And New York Health would pay county and New York City share Medicaid, and the total cost would be less than we're presently spending. Why? Because in fact, the overhead in Medicare is 2%, whereas all of these other private insurers have higher 13 up to 17. And here the RAND Corporation, not a left-wing organization by any means. This is how they calculated things would be. Total projected spending 2022 would be $311 billion in the state. And, there would be a reduction in, insurance administrative costs. Here you see $20 billion. A reduction in doctor, office, and hospital administrative costs of $16 billion. And since New York State would be a very big purchaser of drugs, an $18 billion state patient. So a total of $55 billion. But there would be increased costs if you, cover everyone. Clearly that's going to cost more, $17 billion. And there's a proposal in the bill that Godfrey has, which essentially would increase physician payments up to what private insurance presently pays, and Medicaid and Medicare don't pay quite as much. there would be increased costs of $25 billion, but a net savings overall 9.7% for 29. And New York Health would be able to control future costs better than under private insurance. Here's a very complicated slide describing how much individuals would be paid if your income was below $25,000. You would not have to do anything, but then there would be a graduated. So what are the politics of this? Support for the New York Health Act has surged with Trump cutbacks, and the impact of COVID. It passed the Assembly 87 to 38 years ago. 31 senators presently endorse it. If we had 32, we would have votes enough to pass it, but we probably want a little bit more than just 32 votes. And I think we will have that this coming year. And then, of course, there's the question of hormone disease. So what's next? I think you'll see more statewide hearings, more attention in the media, visible support coming from unions and community groups, but also a much higher resistance from the insurance companies, business interests, and right think. Frankly, there needs to be a lot more strengthening of people and money opposing this. And there is a group called the Campaign for New York Health, which is organizing that. And late, so I'm not going to go with that. Here are some doctors who went to Albany. Many of you are in there, advocating for the New York Health Act. What you can do, learn more about single-payer reform, go to the national website of php.org, contact local activists in the Campaign for New York Health, or even tune in to videos of the forums that we did here on the impact of COVID. The New York chapter is PNHP-. Here are some contacts and references, I'm open to questions, although we are a little bit tight on time.
That's okay. I think we'll have a few questions. We'll start off for people on Zoom with questions in-house, and then we'll transfer over to Zoom. Does anybody, first of all, great lecture. Thank you so much for that. Does anybody have any questions or comments?
No questions.
I'm sure we'll have some on Zoom. Anybody on Zoom have any questions or comments?
I have a question. Can you hear me?
Yeah, we can hear you.
Hi, Dr. Fein. My name's Angela. I'm one of the fourth years. Thank you so much for your lecture. I thought that was a great overview of a lot of complex policies. My question is that you've often framed the preservation of the private insurance industry as a flaw in various proposals for healthcare reform. And I think there's a huge ideological split in our country where some people hold certain values so highly, like individualism or free enterprise and lack of government interference, that they wouldn't necessarily see those as a negative. How would you respond to people like that?
What I would say is that one then has to balance those concerns with the whole issue of, is healthcare a basic human right? Is that something that really is essential to living, is getting healthcare? And if that is, in fact, the way people look at it, it seems to me that using these various market means to control healthcare is a mistake. And secondly, what we've seen is that it leads to this incredible cost that is twice what we see in other Western industrialized nations, all of whom have, essentially, fundamentally, a free market system, but not necessarily in the healthcare field. So my sense is that if you can demonstrate that a private market will allow you to get to the situation of regarding healthcare as a human right, okay, but I don't think that's the way it works.
Thank you.
Any other? Yes, go ahead.
Oh, I was just thanking you for your response.
Oh, okay.
I did have a question myself. So as the perspective of a healthcare worker, going from like a single payer state like infrastructure, how does the healthcare infrastructure need to accommodate to that increased overload of patients so they're not like getting delayed like outpatient follow-up or delayed times in ED? Is there something that also needs to shift in terms of the healthcare system within like doctors and nurses and hospitals?
Yeah, I guess one of the concerns, that the people have raised is, well, if you're going to increase access by insuring the 30 million who are presently uninsured, isn't that going to provide, an overload in the healthcare system that, in fact, will mean longer waiting lists for doctor offices, overcrowded hospitals, things of that sort. And I think the major answer to that is, number one, it is fascinating. If you saw that slide where there was this amazing increase, in the number or decrease in the number of uninsured, which meant increase in people who had insurance when Medicare and Medicaid were passed. But, what happened was that those people were absorbed into the system. And it did not end up, I think, with long waiting lists. It did not end up with a situation where, we weren't able to, in fact, rearrange things so that, there would be a way to accommodate people. We might find, for instance, that we would be doing more virtual visits, right? As a way of trying to incorporate some degree of increased demand in the system. But I think all of those things would be much more feasible to accomplish, frankly, in a single payer system where you could actually allocate dollars to some of those and, not totally deal with a market-oriented way of distributing kits. So it's a good question. But I think it leads to, having a much more creative approach to the delivery of service.
Awesome. And
yes, in the back, I see a question.
Thank you so much for coming. These are such topics. I also wanted to recommend to everybody to read White Coat Punch Fist. Dr. D left out, but about you and your fellow residents advocating for the communities in the South Bronx. And a medical student back then too. I am Dr. D. But what is your biggest fear? I imagine around maybe the Supreme Court and its new justices for the next 4 years of healthcare, and your biggest focus next year of healthcare.
Well, interestingly, the cases that are being brought to the Supreme Court, you may have read about this in the newspapers, that it looks very much like Roberts and Kavanaugh will not accept the arguments that have been made that once you have kind of taken away the requirement that everybody have health insurance and have penalties if you didn't, have health insurance. That was taken away essentially in the tax cut that Trump approved. That would invalidate the entire ACA. And I think they would say no, it doesn't. And the interesting thing is that, it's not clear that the reason that, the uninsured have gone up, frankly, is not because they aren't forced to buy health insurance. People aren't forced to buy it because of the fine, but more because, frankly, they've lost employment, through the COVID crisis. So, I don't know that we will find the Supreme Court being a problem for continuing the ACA itself. Okay. And I think that if we went in the direction of a state single-payer approach, at least for a short period, I don't know that the courts would get very involved. So it's very possible they will. So what I think, the next 4 years would be great is if we could, in the state of New York, actually go in the direction of, a state single-payer program. And it looks to me like there may be some real possibilities that if we got 42 senators in the Democratic Party that would do this, then we would have a veto-proof approach. And Cuomo would not be a barrier moving in that direction. We'll see. We're not there quite yet. Folks have to all be happy.
We have one more question. This will be the last question on Zoom. Robbie, if you hear me, go ahead.
Okay, can you hear me okay?
Yeah.
Okay. So I guess one of my questions is, I agree. It seems like this is a really complicated subject, as Trump said. Never knew health insurance was so complicated. One of the things I've taken away from watching the debates, at least when there was no name calling, was that one of the things that both candidates, Biden and Trump, focused on was about the issue of employee healthcare plans. And so people were saying, I don't want to lose my employee healthcare plan because I like it. So can you just, I guess for my example, for myself, for example, my wife works at NYU and I get healthcare free at no cost. I have no copays. Could you just explain, because I still have a hard time understanding myself, what would happen if New York adopted a single payer healthcare model for us specifically as residents? Would we have added taxes? Would it eliminate our healthcare plan that's given by hospitals, for example, like NYU?
Basically, the idea, if it were truly a single payer approach, would be that private health insurance would not be permitted to duplicate the coverage that is offered in the single payer. Okay. Yes, private health insurance could supplement things that were not covered in the single payer approach. But that's yes. What would happen is that most likely you would not have employment-based private health insurance. But hopefully the substitute for it would actually be better than what you're getting. I'm surprised that, if you have an NYU policy, there isn't any deductible. Are you sure?
No.
Pardon?
As far as I know, no.
I'm very dubious about that. There are no co-payments.
Correct. I had surgery this summer, and I paid I paid no bills.
Well, that's really interesting. I mean, it's very unusual that you have a private health insurance policy that is structured that way. But you're paying for it, or if you don't work at NYU, your wife is paying for it, because what's happening is that is being deducted from her salary. You know, the amount that in fact goes into buying that health insurance is part of the fringe benefits that she actually pays. So you should look that up and see how much it is. I would submit that most likely, it's going to be somewhere in the $7,000-8,000 range.
Awesome.
It's an interesting piece of research you should do.
Thank you again, Dr. Fein. I think everyone really appreciated your overview and how you simplify the complexity of this.
Okay, well, listen, thank you so much for inviting me and for people coming out. That's always a difficult thing to do in these COVID days.
Yeah, especially for you. So thank you. All right, thank you.
Then I tried, me and Sophia and Monisha tried to talk him out of coming here and doing it via Zoom. And he is so principled. He said, no, I always do this face to face. And in fact, when I sent him one more email and said, why don't you stay home? It'll be easier. You don't have to worry about COVID. You don't have to worry about parking. You don't have to worry about the weather. Immediately, he sent out another memo to us saying, I'm coming. That's how principled he is.
Thank you.
Thank you so much.